Hello. Good evening, everyone. So I'm Noshin, as most of you already know. So we this is our second live session. Hope you all are doing very well. Thank you for joining us. Yeah. Okay, so today mainly the topic I chose to talk about is the things that you will need to do after coming to UK. The ST3 application, portfolio build up, some of these things you can start when you are in your country as well. That's the only reason. Yeah, good evening. So that's the only reason I chose this topic to talk about because when I was back in Bangladesh, this topic was quite unclear to me. I didn't know exactly what to do and how to build up the portfolio and everything. So before going to our main topic, I will like to share some I'd like to start with an apology actually, because last week I received a lot of messages from you. Thank you so much for your response, but I think I could not answer all of your text because here the weekday rotas are like sometimes we have to work 9 hours, sometimes 12 hours. So I was on nights last week. So sometimes this is long tiring shift. So I can't manage to reach everyone individually in inbox. So, but please be informed that your queries are, I see all of them and I try to include the topics in my post or videos. So please don't stop commenting or responding. So today, I received a lot of questions last week between PLAB and MRCS, which one to choose and which one is better. Basically, I personally I do not like to persuade anybody that no, do this, that is better. I believe that it's completely depends upon the person what they want to do. So if you want to be a surgeon, if you come to UK, that is one way of life, but that doesn't mean that you can't do anything else. But still, if you want to know that why I chose this way, why I chose to be in surgery, well, surgery, I always wanted to be in surgery. So that's not the question why I chose to come to UK or why I chose to give MRCS. So the only thing I noticed during giving the MRCS exams is I quite like their question patterns. So as a doctor, I feel like knowledge varies person to person. You can read all the textbooks, you can gather a lot of knowledge, but to serve your patient well or to work as a team member for the better treatment of patients. You need to be a good team member, you need to be a good leader sometimes, you need to lead your team, and you need to be really passionate to your patients, and also clinical skills, technical skills. So I feel like it's not only about seeing the patient or knowing more than anyone else. It feels like it's a complete package. So when I gave MRCS, the MCQ exam style, I quite liked them because it's more organized. As in, if I talk about MRCS Part A, that is the question patterns. If I believe that a lot of you have already started to prepare for MRCS Part A. So the question patterns, as in for anatomy, as a medical student, I was always afraid of the relations, the attachments. I mean, thousands of muscle attachments, thousands of relations. I had really difficulty to memorize all of them when I was in medical school, when I was giving professional exams. But when I started studying for MRCS, so these things became, because they make these questions like a story. So they will they will come up with a entire scenario So you are assisting a hepatobiliary surgeon for say lab a um, gallbladder surgery or Whipple's procedure, so or maybe abdominal trauma. So when you enter into the abdominal cavity, you notice that there are a lot of bleeding coming in, and then the person is becoming tachycardic and hypotensive, and the person is going into shock, and then uh, your consultant puts a finger on some structures through a foramen, and the bleeding stops, and then the blood pressure starts to rise. So then they will ask this question that which foramen do you think that is, or what is this maneuver called? So for like for me, it's like rather than just memorizing epiploic foramen or okay, it's the Pringles maneuver. It's when it's a scenario, it's a I start to imagine like, okay, I'm in that surgery, I am treating this patient. So that's when I realized that why it is important for me to know about epiploic foramen, or why it is really important to know that what the relationship or different structures in epiploic foramen is. So in epiploic foramen, there are three structures. There is a common bile duct, there is hepatic artery, and then there is portal vein. So that duct is to the right, and the artery is to the left, and the vein is behind that, and behind the vein is inferior vena cava. So when I was a medical student, I could never memorize that. I mean, what is in front, what is behind. I'm sorry. So it was all confusing to me, but when I imagined like this, that okay, this patient, I am in the surgery, I'm doing I'm assisting this, and this is a procedure, this is related to a procedure, so I need to know from where this bleeding is coming from. So I need to know the exact position of these structures. So then it starts to hammer your mind that okay, so this relationship is important. Another thing is, they will make a scenario that a person came with stab injury to the groin. So they will say that there is a profuse bleeding. So then they will ask about that when where does the femoral artery lie. So if you don't know the exact surface marking of the femoral artery, so you will not be able to like categorize that is the, because sometimes they will say that the uh, stab injury is to the lateral side of the thigh. So then, sorry, not thigh, is the inguinal region. So then you can just say that okay, so the artery is more medially, so there is less chance that the artery will be injured. So this were this is just one or two questions. There are 1,000 to 1,200 questions altogether in anatomy, and each one of them, they will make a story. So these stories attracted me to study anatomy. So if I be completely honest with you, I never studied anatomy with much interest before I gave MRCS Part A, because all these stories, all these scenarios, and when I imagine that okay, I'm receiving this patient with this stab injury, and I need to figure out if the stab injury is in this place, that which is the first structure I should suspect that could be injured. So that was the first time I actually felt the urge of knowing exact relation of anatomical structures. So goes with the muscle attachments. I when I gave MRCS Part B, I almost memorized all the muscle attachments, like or at least the big ones, the important ones. So I could never imagine that when I was a student, or even when I was studying post graduation. So this is one part. And then when the clinical part comes, the surgery, so there is neurosurgery, there is so as for neurosurgery, for example, they will make a question like, you've got a 80-year-old female who fell in the bathtub, and then coming he's she is, or she has altered consciousness, and then CT scan shows some hematoma, or so what do you suspect, what could be the case? So old age is old people are particularly prone to having subdural hematoma, whereas extradural hematoma is much more likely when a person has some accident, some kind of head injury. They lost consciousness in the accident site, and then they regained consciousness, and then when they came in the hospital, they are again becoming unconscious. So this is the lucid interval. This is quite common in extradural hematoma. So these are some 2 or 3 points when you can differentiate which one is extradural, which one is subdural. Specific book you suggest for anatomy? Well, as I have already said a lot of times, that I always suggest that solve as much questions as you can. I mean, just reading the books thoroughly will not help you to find out these tricks they use in their questions. So you have to find out the tricks. You have to know what they want from you, and then as in book you can keep I had that BD, I had Datta anatomy, I had Neater, I had Raftari. So it's, I can't say that I memorized all of them. I just had them, and when I needed to clear my conception, I would just take them out and just read the part. But mostly I solved questions. I mean, there's no way that I'm saying that no, I memorized this book. That won't be truth. Well, so then talking about the clinical part. So as in this thing, you can differentiate the extradural and subdural hematoma. This much they want from you. They don't want that you will know a lot of information about neurosurgery or general surgery. For general surgery, they will just ask that a person is coming with bowel obstruction, bowel not opening for 7 days, and he's vomiting, and then yeah, he's got weight loss, so he has constitutional symptoms, and then you already know that this person has a bowel cancer. So then they can ask that what is your diagnosis, then you can say that maybe colonic carcinoma. And if they say that the patient is anemic, then maybe right sided colonic carcinoma. If they say that the patient has tenesmus and altered bowel habit, diarrhea, constipation, then maybe it's left sided colonic carcinoma. So, and then maybe they will give you the diagnosis. Okay, this patient has colonic carcinoma. Now, how do you investigate him? So the trick here is you cannot say that okay, carcinoma, now I go for surgery or I do colonoscopy. So when there is an obstruction or any kind of infection in the colon, you never go for surgery or any scope. You go for CT scan first. And if you are suspecting malignancy, given patient's age, patient's overall symptoms, patient's onset of symptoms, so if you suspect that it could be malignant, you have to do a staging CT scan and tumor markers. So based upon your options, you can choose that either I have to go for CT scan of thorax, abdomen, pelvis, or tumor marker. And then they ask you that what do you do next. Here one simple mistake is some people end up like, okay, I know that this patient has malignancy, right sided colonic carcinoma, CT scan shows, so okay, right hemicolectomy. No, you never do that. You have to arrange an MDT meeting, and you have to escalate it, because you have to understand that in the scenario you are the SHO. There's no way SHO is doing the right hemicolectomy here. So you have to escalate to your register. So your option will be escalate to the register, and then um, you know MDT meeting, and after the MDT meeting, then surgery, and after the surgery, like post-op management, or if needed, oncology follow-up. So that's it. So they will ask you either the diagnosis or the investigation or the management, if you talk about clinical parts of surgeries. You advise EMRCS and pass test, that's all. Okay. It's like when I took preparation, I first started EMRCS and pass test. I solved all the questions 3 times, and after 3 times, I started to feel like, okay, I understand what they want from me. And then I solved recalls, and then I solved some mastering. Mastering MRCS is good for self-assessment. You can try this. So I'm saying that EMRCS and pass test is the skeleton of your preparation. After this preparation, if you feel like you need to do some more self assessment, you can go for mastering, you can go for Prodeep. But one thing I know, that you will not find a lot of new questions there. It's just, what happens when you solve past test and EMRCS for 3 to 4 times, you kind of memorize all the questions. Just seeing the first line of the question, you just know that this is the answer. So sometimes then you need some new materials. So then you go for recalls, then you go for mastering. It's I'm just saying, it's up to you, it's totally up to you. I'll just say that, keep preparing till you feel like you are confident enough with their examination system. That's all. I mean, it's not that I have read EMRCS, so if you can't read EMRCS, you can't pass this exam. This is not like that. This is all about your confidence, this is all about your comfort zone. Okay. Coaching, yeah, I for part A, I went to SS Academy. So at that time, I didn't know a lot of people who are giving MRCS. So I didn't have any partner or anything. So when I went to the coaching, it gave me a big circle that I could talk to them, I could ask for their advice, I could so I found my partner there. So it was helpful for me. And for MRCS part B, I did a course in India. So these were all like to aid the preparation. So then after we passed, we tried to help as many students as we could. Genesis is nowadays, I think a lot of coaching centers, SS Academy, Genesis, and some other coaching centers, they all are working for MRCS Part A and Part B preparation. So yeah, I think that nowadays you are actually privileged with lots of guidelines you have. So when I started, it was not like that. Anyway, so let's not like slip from the topic. I was talking about the clinical scenario. So the clinical scenario will be like this: they will give a scenario, they will give you a story, and then they will ask for what is your diagnosis, and then they will ask that if it is your diagnosis, what is your investigation plan. And in terms of after giving investigation, they will ask, what do you think the most prioritized management should be. So that's the 3 lines of question they ask. So you actually can relate to these questions, that's what I mean. And then there will be some preoperative assessment and postoperative complication related questions. Because when you come here, or even in your country, as if you are working as a junior doctor in surgery, you have to manage the ward, you have to cover the ward. So any patient, what should be the preoperative preparation if the patient is diabetic, if the patient is hypertensive, if the patient is on steroid, if the patient has thyroid problems. So what should be your extra preparation for the surgery, and what complication do you expect to happen from the surgery. As in, for colonic surgery, any colonic surgery, ureter injury is one of the most most possible complications that can happen intraoperatively. If you go for if you are doing some thyroidectomy, so the internal laryngeal nerve, the recurrent laryngeal nerve, those things are quite close to this structure. So these are some common things they expect you to know. Okay, so yeah, and that was about MRCS Part A. So when I was preparing, I could relate a lot with the questions. So that was really helpful for me. And then MRCS Part B. So this part taught me how to deal with a patient, a colleague, a patient's relative. This is like did you course in India arranged by RCS? No, it was not arranged by us. Though RCS arranges these courses every year, but that was arranged by Vincis, not RCS. It doesn't matter though. I mean, it's just you need to practice with some people you are not comfortable with. Because, for us, like we have always been a doctor in Bangladesh, so we are not really that much comfortable with speaking in English to some unknown person and taking history. So it's just to make you acknowledged with the total scenario and comfortable with this thing. So no, you don't need any training for MRCS Part B. So yeah, during MRCS Part B, you have to speak with the patient. You have to do breaking bad news. You have to take full history in 6 minutes of time. You have to do complete physical examination, and then, excuse me, if you have to answer the short answer question answers. You have to communicate with patients relative who's angry, who's anxious, and then you have to communicate with your colleague who sometimes misbehaves with you. So this kind of scenarios, I think that when I came here, so this kind of scenarios happen all the time. I mean, now I can say that everything I learned during my MRCS Part B, every bit of it was related to practical life. None of them were like, okay, I don't know why I did this. This is not like it. I mean, every day I have to face similar scenarios like MRCS Part B. So I think that it's a more relatable exam. So that's why, I mean, it really teaches you how to deal with your practical life, patients, colleagues, or patients' relatives. So I think this is a very important part of medical science, of your profession. So from that point of view, I would really recommend that if you give MRCS, then you have a brief idea about what you need to do as a doctor. So yeah, that's it. Yeah, so I'm coming to portfolio now. I will not make this discussion any longer because the portfolio thing is quite long. So the people who are planning a career in surgery, so I divide them into three parts. Some of them have just started, have not is preparing for MRCS Part A, and some of you have passed MRCS Part A and they are preparing for MRCS Part B, and some of you have passed MRCS Part B but still not moved in UK yet, maybe completing the residency, completing other courses they are in. So today's live session is mostly focused on those who have completed MRCS Part B, is planning to move into UK. So they need to know that what can you expect after coming here, and what will be your next step of your career. And also the students or the fresh graduates, you need to know some valuable information. So this portfolio thing is very, very important, and this information actually you can't get commonly anywhere. I can say that because when I was in Bangladesh, I didn't get this information sitting there. So I would say that please be very attentive to this part and try to understand what I'm saying. I'm happy to answer any questions, but still just make sure that you are giving proper attention. So at first, I'll discuss. I have already discussed about the. Sorry, I'm not taking any questions at the moment because I really need to complete this. So just feel free to drop your questions. I'll answer them later. So as I have already discussed the training program of UK. So to become a complete surgeon is like after you complete graduation, you do 2 years of foundation year, which is equivalent to our internship. So FY foundation year 1, foundation year 2. After that, they get enrolled in core training 1 and core training 2. This is also for 2 years. These are different specialties in surgery, but they are like just preparing to get into surgical training. This is not specially surgical training, but this is to have an overall idea about all the specialties. So I think that here people can then properly decide which specialty do they want to go. After that, they apply for specialty training. So ST starts from 3, as in 1 2 is already gone in core training. So in general surgery there is ST3 to ST8, so there is 6 years. So FY1 to CT1 2 and ST3 to 8, total 10 years of training, and then they are eligible to sit to FRCS. And MRCS is mandatory before you apply for specialty training. For foundation year and for core training, MRCS Part A is mandatory, but not like or desirable. But it's not that you have to complete MRCS before core training, but before specialty training, you have to complete MRCS. And after 6 years of training, you are eligible for FRCS. And but after passing FRCS, you don't become a consultant. You then still you have to complete your CCT checklist, which is completion of clinical training. Yeah. So CCT checklist is actually no need of our discussion at this moment, because that is like way ahead of our journey right now. So I'll just discuss about the foundation year training. The people who are completing their internship from other countries, they can get their FY competence form signed by their consultants there. You can find the form online if you search. So there is no need coming here to come here and then apply for foundation training. So I would suggest that those of you who are junior fresh graduates and planning to come here within 1 or 2 years after your graduation, just aim for core training. And those who cause for core training, you cannot show more than 18 months of surgical experience. So apply for core training, and then it will become a lot easier for you to get into specialty training. Yep. And for those who have completed MRCS Part B and has like 1 or 2 years of experience in surgery back home, for those I would suggest to go for specialty training. So today the main discussion will be how to build up your portfolio for specialty training. So for specialty training, you have to apply you have to apply in January. There are a specific website, Oriel. You have to create an account in Oriel and apply through that, and then you have to give an interview. The interview happens in March. And then you in the interview, there are 6 categories you get judged on. So one of them is portfolio, and then there is clinical scenario, then there is management, then there is professional communication, and then there is academic and technical. So these things will I know it sounds a bit confusing. I mean, what are even these things? So it will become a bit clear maybe after the session. So first, let's talk about the portfolio. Let's talk about how will you know that you are eligible for giving the interview. So for giving the interview, you have to complete your MBBS. Yeah, essentially, of course. And you have to complete your MRCS before you apply for it. And you have to have complete GMC registration and full license to practice as a doctor in UK. And you have to have your CT2 competence form signed. Now, this is a bit confusing. Some of them say that you can get it signed by the consultant, and back home, some of them say that you can get it signed here. So the thing is, any consultant who has supervised you for 3 months can sign the city competence form for you. So I would say that you cannot apply within 6 months anyway. After coming to UK, you have to at least spend 6 months in the system to understand what is going on around you. By the time you can like the consultants know you, so you can get the city competence form signed by them as well. But FY competence form you can sign from your consultant back home if you are like planning to apply for city application here, and then be eligible to work in UK. Yep, of course. So then portfolio. The first thing is, how do they assess your portfolio? They assess depending on 9 things. So I'll go one by one. Number one is postgraduate qualification. So here, for those of you who are asking that why should I give MRCS, why should I give MRCS, why shouldn't I give PLAB? So PLAB and MRCS, both of them will give you the opportunity to complete the GMC registration when you are coming to UK. And after coming here, before you apply for ST3, you need MRCS anyway. So my theory is, why if you are completely sure that you need to you want to go to surgery, then my thing is, why should I give plab and then come to UK and then give MRCS? Like, you can just give MRCS and come here and then start applying for ST3. That's my theory is. Otherwise, it's fine. But you have to complete MRCS before you apply for ST3 training, even if you are coming through plab route. So this is the funny thing is, for MBBS and MRCS, you don't score any marks in this category. So they have some 1 year and 2 year 2 year degrees, MSc, BSc, diploma. So based upon how many years you have done in those, like if you have done 1 year, if you are in progress, if you have just started your MSc course here, you will get 1 mark. If you have completed 1 year, you will get 2 marks. If you have completed 2 years, you will get 3 marks. If you have completed 3 years, you will get 4 marks. And if you have completed MD or MS, so you will get 4 marks. So if you have completed your residency back home or here, then that gets you some extra points in this category. But yeah, so that's it. So I'll say that for the people who are not in any residency training, who are coming straight here, for them, you can just apply for any MSc or BSc or diploma course here and get enrolled in it, and then you get 1 mark. So that's the fair thing you can do. And if you are just planning to complete your residency back home and then planning to come here, then it's also fine. Second category is academic award and prizes. For those who have passed any professional exam with honors mark in any subject, or has some undergraduate or postgraduate prize, so they will score some extra marks in this section. For me, it's like a big zero. But if you have achieved any undergraduate prize, you will get two, or 1 or 2. And if you have achieved any postgraduate awards or prize, you will get 2 or 3, 4. And if you have achieved any Royal College prizes like Moynihan Prize, there are specific 2 or 3 prizes, they will give you 5. So yeah, yeah. So for people like me, it's a big zero. Then okay, don't get disheartened from the first two sectors. Just it's just, I mean, if even if you score 0 or 1 in these two sectors, it doesn't matter. Then it comes to clinical knowledge and experience. So there are some terminologies here which you need to understand. So one is MSF. So one is WBA and one is PBA. W আমার বাংলাতে বলতে কোনো সমস্যা নাই। I can see the comments that বাংলাতে বলতে অনেকে রিকোয়েস্ট করছে, বাট দ্য সমস্যা হচ্ছে যে ইন্ডিয়া থেকে, নেপাল থেকে, পাকিস্তান থেকে কিছু কিছু স্টুডেন্ট আছে। সো I don't want to leave them behind actually. I'm sorry. I mean, আমি বাংলাতে বলতে খুবই পছন্দ করতাম। It's not যে আমি বাংলা বলতে পছন্দ করি না, কিন্তু আমি জাস্ট ওদের জন্য ইংলিশে বলছি। I hope sorry about that. So one is WBA and one is PBA. So WBA is word based assessment and PBA is procedure based assessment. So word based assessment is the works you are doing in Word, which is essentially how you are taking history of a patient, how you are doing examination on a patient, how good you communicate with your patients, how good you communicate with your colleagues. So all of them are in WBA. It's clinical knowledge and experience. And the when you do some procedure, be it any surgical procedure or anything, that goes under PBA, which is procedure based assessment. So both of them are different categories. So first, in WBA, you have to be able to take proper history and examine and diagnosis some cases, and among them they have 5 significant cases: limb ischemia, hernia, biliary colic, peritonitis, bowel obstruction. So these 5 things, you have to be able to do assessment and diagnose these cases properly. So in this WBA, they have 3 categories. One is MSF, which is multiple source feedback, one is mini cakes, which is clinical examination, and one is CBD, which is case based discussion. If I say in simplest language, when you see a patient, when you are seeing a hernia patient and you are discussing this patient with your consultant, that okay, um, this patient came in with swelling on the right inguinal region, and then I examined the history is like this, and I my examination finding was this. So that is a CBD. That is a case-based discussion. After discussing it with your consultant, you can send him a form that okay, I discussed this case with you, and now you have to sign it for me, and then it goes to your portfolio. Like cakes, it is clinical examination. So you can after examining the patient. Um, I'm sorry, a lot of you are requesting to say in Bengali, but it will then, the students from other countries, they will lose it. Sorry. So clinical examination, if you examine a patient, then you can send the form to your consultant that, okay, you have examined this patient, and this the patient should be in this five diagnoses. And multiple source feedback is feedback from your colleagues, feedback from your patients. So there are so people here maintain a ISCP logbook, which is a e-logbook. So you have to buy it online, and there are these specific sectors. I will just show you mine. So it is like uh, you have to create an account, then you have your email ID and password, and when you log in with your email ID and password, it is something like this. I hope you can see this. So if I go to add here, so these are different categories. I have added these screenshots in a presentation. I'll give you the presentation. So if you go to cakes or if you go to CBD, you will be able to add these things, and there are multiple source feedback forms. So multiple source feedback forms, you don't have to get it signed from back home. The thing is CBD and cakes, the case based discussion, and then the clinical examination, these things I would particularly say the third year, fourth year, or final year students. So you are doing a lot of history taking and examination these days. So I will give you the format. I will provide you with the presentation. I made a PowerPoint presentation for you. So I'll give you the format. If you there is a form, I'll give you the PDF link. If you print out the form, and if you just add that okay, this patient I have taken history, and this patient I have done the clinical examination, and if you get it signed from your consultant including the hospital name and your consultant's BMDC number, so you should be able to submit it in your portfolio. So CBD and cases, I'll say that medical students be just you can easily. So you need at least 10 CBD and 10 cakes before you apply for ST3. So I think like you see a lot more than 10 cases. So it should not be very difficult to get 10. Actually, you can get 20, 30, as many as you can, as you wish. So then there are different levels of judgment. So there is level 1, 2, 3, 4. So level 1 is appropriate for early years of training. So this is appropriate for foundation year training students. So and then level 2, 3, 4. Level 4 is the highest level. So the thing is, if you want to score 5, which is the highest in this WBA section, you have to get at least 10 CBD and 10 cakes signed by your consultant mentioning that you are level 4, which means that in simple language, that you can confidently take history, examine and diagnosis a patient with limb ischemia or hernia or biliary colic or peritonitis or bowel obstruction, and then then your consultant have to verify it, and then you can submit it as evidence in your portfolio. I'll just repeat once more if you are still confused. So you have to have 10 CBD and 10 cases with level 4, which means that you can confidently diagnose these five kind of patients, and you can do the history and examination, and your consultant should sign that, and you can submit it in your portfolio as an evidence. So that was the WBA thing. If you are confused from what I'm talking, I have the presentation. I will give the PDF link. If you see the presentation, I hope that these things will become more clear. I totally understand that you are not getting it 100%. Honestly, I spent last 4 months to figure this out, so please don't be disheartened if you are getting confused with this. These are not like these are not very difficult things, but we are not familiar with these things, so it took me 4 months to figure all this out. So if you just see the presentation, it will become more clear, so don't be disheartened if you are not getting me. Okay, now, the next section is PBA, which is essentially technical knowledge and experience, how good you are with procedures. Here also, so they are quite specific about what they want from you. That's the only good thing. So in PBA, they have PBA and DOPS. PBA is procedure based assessment, and DOPS is directly observed procedural skills. So DOPS is bigger PBA, as in if you do some small procedures like abscess, or some port placement or some groin exploration, those are PBA. And if you can open and close an exploratory laparotomy, and if you can repair an inguinal hernia all by yourself, if you can do an open appendicectomy all by yourself, that will be DOPS. So bigger PBA is DOPS in simple language. That's why. So in PBA they have five things: abdominal wall hernia, groin exploration, appendicectomy, laparoscopic port placement, abdominal wall incision. And in DOPS, they have appendicectomy, inguinal hernia repair, emergency laparotomy repair. So again, the level comes. So level 1, 2, 3, 4. So the consultant should verify that you have level 3 or level 4 competence in these procedures. And all these five things, you have to submit at least 3 cases of each. What I mean is, you have to have 3 abdominal hernia, 3 groin exploration, 3 appendicectomy, 3 laparoscopic port placements, 3 abdominal wall incision, 3 appendicectomy, 3 inguinal hernia repair, 3 emergency laparotomy repair, 3 of each, and your consultant should verify that you are level 3 or level 4 competent in these procedures. Then you can get a 5 in this section. So for those who have completed your graduation, doing your internship, I'd say that please take the advantage. When you are an intern, you are like their babies. So whatever you want, they give you, because this is your medical, this is your consultant, this is your registrar. Just go and give them puppy eyes and tell them that, please, I want to explore this groin, please, I want to do this port placements, please, I want to repair this inguinal hernia, and then get the form signed by them. I have added the PDF form in my presentation. You will get the form there. So print out the form and then fill it up and then get it signed by your consultants, and then you can submit it in your portfolio. Yeah. So for students, go for the WBS. For interns or who are in training, go for the PBS. Get as many signed as you can. Well, I understand that it's not clear. I totally understand that it's not clear yet. Please, like, uh, sit patiently till the end, and when you see the PDF presentation, it will be because I am telling again and again that it took me 4 months to figure this out. This is not like, I mean, that simple. Anyways, the next category is courses. Well, this is easy money. You can get 5 easily. You have to complete 9 courses. So mandatory is ATLS, crisp, and basic surgical skill. So these courses you need to do, that is mandatory. Without getting these courses done, you will not even be shortlisted for the interview. So you need these three courses, and after that you have to complete six courses in general surgery or vascular surgery, and then you can show them as your commitment to surgery. As I said, that in this portfolio thing, you have to show that you are a total surgical junkie. So when you will show that I have done this CBD, I have done these cases, and I have done these procedures, I have done these courses, so then they will understand, okay, you are really really committed to surgery. So if you do 9 courses, you will get a 5 easily in the course section. Okay, then comes audit. um yep. So about the audit, you have to do at least 10 audits to get a 5 in the audit section. And about the publication thing, so if you have at least 2 significant case reports, you get a 1. If you have 3 case reports or 2 publications in national or international journals, you get a 2. If you get more than 2 publications, you get a 3. If you have more than 4 publications, you get a 4. If you have more than 7 publications, you get a full 5. So for those who are doing internship or who are fresh graduates, I would say that you can go for this one. So if you ask one of your consultants who are interested in doing publications, if you help them, if you can get your name on them, maybe you can get 2 or 3 easily in this section. And if you have already completed your MRCS, and if you are planning to move into UK within like 3 to 4 months, please don't get disheartened that you can't get any publication done by this short time. It's just one category of one station, so don't get disheartened. If you can just manage to get a 2 or 3, that's fine. Like, um don't be too worried about this thing. And then comes presentation. So there are also 1, 2, 3, 4, 5. If you have one regional presentation, you get a 1. If you have 3 poster presentation, you get a 2. If you have 2 oral presentation in national or international meetings, you get a 3. If you have 5 oral presentation, you get a 4. And if you have 7 or more oral presentation in national or international meetings, you can get a 5. So um sorry, I'm dehydrated. So um yeah, where was I? The presentation thing. um if you get yourself if you get a membership in any um surgical, there are different surgical societies. There are ACID, there are in Bangladesh there are SOSB. So if you can get a membership in one of those societies, they do conferences from time to time. And then if you can present 1 or 2 cases, 1 or 2 posters in those meetings, even if you have made one presentation in your hospital, you still can get a 1. So try to score 2 or 3 in this section. So for those who are still in internship or in training, I think this CBD, this cakes, this PBA, and this presentation publication thing, if you start to work on these things, by the time you come to UK, you will have a stronger portfolio than we had when we came here. Okay, next comes the teaching. So the teaching thing is you can do it at different levels. You can teach the medical students, you can teach in a bigger circle, postgraduate or anything. So you can get some courses done. So there is a course called teaching the teacher or training the trainer, whatever. So if you do that course, it gives you 2. If you can work as an ATLS instructor for, say, you can get a 3. And if you have played a leading role in course, as in some of you who are in post graduation, you run post graduation coachings, so you can show that in your portfolio. But the only thing you have to have is a certificate and also a feedback form. I have added the feedback form in my presentation, so you can print out the, I'll give you PDF link as well. So if you can print out the feedback form, and if you can get it signed by the people you are teaching, then you can add it to your portfolio. So I'd say that get yourself engaged in teaching, whichever level you are at. If you are an intern, teach the fifth year students. If you are an HMO, teach the interns. If you are a assistant registrar, teach the, like, immediate juniors, whoever you have. Six, like, it doesn't matter how many people, five, six, seven people are fine. Get the feedback form signed by them, and then you can submit it in your portfolio. Okay, so that's again easy thing. Management and leadership. Okay, this is like, if you have organize small activities, as in some people are um, involved in debate competitions or cultural programs, or arranging some study tour. You can get it signed by your professor who was the supervisor, and you can show it. If you are organizing regional meetings, so as in every government medical or private medicals as well, there is a weekly academic meeting. So if you can show that I've been organizing those meetings, you can show it as a leadership activity. The funny thing is, in your medical school, if you were a debate club leader, or if you were a football club captain, you can show that in leadership as well. It doesn't have to be essentially have to be in clinical or medical things. And if you can show that you have represented any national role, as in any national competition or anything, so you can get a 5. So that's also, I think, the students should be working on. Then try to arrange these small things in your medical school, in your district, and if you can do anything national, so it gets you a total 5. So that was it. There is total 9 stations, and if you are even more interested, you can log into ISCP. But if you are not moving in to UK at this moment, I wouldn't suggest you to go for ISCP, because you have to pay for it. I mean, I don't think that's necessary at this moment. If you are planning to come here within 1 year, then you can definitely go for it. And then there is an website Oriel. You can create a free account, and then you can see the whole application process. Mm, then you can subscribe in Medibuddy. That's also, I think, paid. So there they have different scenarios, different clinical scenarios, management scenarios. So say for, they will ask you, if you are a ST3 on call, and you get RTA patient in A&E, and then your intern is struggling with palliative care patient in ward, and then your SHO said that some medical registrar is misbehaving with him or her. So which one should you deal with first, and how should you prioritize, and how should you manage this whole situation? So and then there something comes up, if some consultant comes up in the ward, and he's like smelling alcohol, you can smell alcohol, then what should you do? I mean, this kind of different category questions. So I am currently preparing with this medibuddy thing. I will try to share some of my scenarios if I can, but it's only for them who are planning to come to UK within 1 year. Otherwise, if you are a medical student, I repeat, if you are a medical student, get your CBDs, KEXs, and PBS done by your consultants. If you are an intern, get as many PBA and DOPs signed by your consultant. If you are a student or intern or postgraduate, whichever level you are at, try some teaching, and try some even if you can't do any audits in your hospital, just at least try to do some presentations in national meetings, and try to work in 1 or 2 publication with your consultant. So this way, I think you can make your portfolio stronger. And yeah, Another thing I wanted to discuss about is there is a multiplier thing. Um, just give me 1 second. So the multiplier things is your score depends upon like gets multiplied depending upon the years you have passed after your graduation. For say, if you are less than 4 years after you have passed your MBBS, your score, as in the score I have mentioned, so there are 9 categories, and each of them has 5 marks at highest. So total score is 45. If you get a 30, then your score is multiplied with 1 into 2/3, so your score becomes 50. If you are less than 5, it's multiplied with 1.5. If you are less than 6, it's multiplied. Okay, what I mean to say is, if you are less than 7 years from your graduation, your actual score will be multiplied, and if you get a 30 to 35, that's a good score to go for this application. That doesn't essentially mean that if you are 7 or more years from your graduation, that makes you any less eligible for the interview. You can still go for it. And this is the portfolio is just one of the stations. Then there is clinical scenario, there is management, there is professional communication, there is academic, there is technical. So if you are more than 7 years, if you have passed more than 7 years after your MBBS, that essentially means that you have like a fair chance in these scenarios. So please don't get disheartened. But uh, what I mean to say is, the sooner you start, the better it is for you. So it's just, I mean, you shouldn't really wait for anything else. So this is why I always say that it is really important you fix your journey when, excuse me, when you are in third year or fourth year, so that you can like start preparing at a very early period, and you have like this definitely adds to your advantage when you go for the interview. So that was all I had to discuss about this portfolio. um so I think it's 8 o'clock. So I'm done with today's session. I hope that I could explain as simple as I can. I tried to keep it as simple as I can. It's just you have to be like familiar with the terms they use. Otherwise, I mean, you know how to take a history, you know how to do an examination, you know how to do these procedures. What we our mistake is, we don't document all the things we are doing. So we do all these things during our early training years or our internship time, but none of them are documented. So they are just like lost in the time. So I would say that those who are the students, try to get prepared from now, and again try to be very very specific about what you want to do. Don't be like just don't spend 1 or 2 years after your graduation, after your internship, just deciding what you want to do. That's not worth it. I mean, you cannot waste that time. So if the sooner you start, the better chance you have. So yeah. And next thing is, you should be very confident. I mean, the third year fourth year students, I'm speaking to the students, I'm speaking to the interns, I'm speaking to the trainees. You should be very very confident at what you do. So as a doctor, you should show that dedication, that confidence to your patient, so that they can rely upon you and your colleagues can rely upon you. So that's the whole point of this um, training thing, what I gather. So you should be really good at teamwork, you should good at leading people. You Sorry. So That's my suggestion to you. I hope that you will start to do all these things as I advised. So today I'll not make it any longer. Thank you so much for joining me in this live session. The Ramadan month is coming. I really hope that you stay very healthy, you stay safe, and keep me in your prayers, and work hard dedicatedly. I truly believe that the young generation, the students, the interns, the early year trainees, these are like most empowered part of the health system in our country. So I truly believe that if you really want to do something, there is no way that you won't do that thing. So do not doubt what you can do. Just keep believing yourself, and just go for it. Thank you, Tarek. Thank you, Elite Medical Forum. Thank you, Genesis, for giving me this platform to come and join with my juniors to speak to them. I hope you stay well. I'll get in touch as soon as I can again. Till then, just stay safe. Bye bye.